Hi, everyone. Thanks again for being here. We will just give folks just a few minutes to get settled and to join us. Thank you. Good to see you all. Good to see familiar faces. Hi, Jill. And
Hi.
hi, Amy. Hi, Amy. Can everyone hear me? Okay, great. Thanks, everyone. And Bijou, good to see you, Bijou. It's been a while. Hopefully, you're doing well.
Yeah.
Lovely to see you all. Jess, what do you think? Should we get started in the interest of time and folks can trickle in? Okay.
I think that sounds great. We want to keep this short. We know you all are very busy.
Yes. All right. I'm going to share my screen. Can you all see these slides okay? Okay, great. Well, I will get us started. So thank you everyone for joining us this afternoon. You are here because you are interested to hear a little bit more about a pilot intervention we have the pleasure of conducting with UC Davis, PC Care, Parent-Child Care. So I'm going to quickly introduce myself and my colleagues. And sorry if it is repetitive information, but just a quick background of care and what we do. And then we will go right into the information related to the intervention. And as Jess mentioned, we want to make sure to save some time at the end for any questions that you might have. So for those of you who may not know me, I'm Lena Zara. I am the program officer for IRC and CARE. I have the pleasure of being joined by my wonderful colleagues, Jess Stalpy and Shefa Obayed. And Jess is our CARE project manager and co-investigator, and also our senior technical advisor on safety and wellness. And then Shefa is our technical advisor as well on safety and wellness. Again, apologies if this is repetitive, but want to be mindful for those who may not be familiar with us. So we are on behalf of CARE, so the Center for Adjustment, Resilience, and Recovery, which is a project of the IRC, the International Rescue Committee. So the IRC is a humanitarian organization that was founded about 100 years ago, providing support to individuals and families and children impacted by conflict and crisis. And we provide support in over, I believe now we're at over close to 50 countries and 28 US cities. CARE specifically is a partnership with the National Child Traumatic Stress Network, really ensuring that families, youth, individuals impacted by forced displacement receive culturally responsive, evidence-based and trauma-informed support and services to mitigate and prevent the impact of traumatic stress. So CARE's work in providing quality, holistic mental health and psychosocial support resources and services um, for families who have been impacted by forced displacement. You can think of CARE almost like acting as a bridge between agencies that work primarily with refugee immigrant populations and then also mental health providers. And how do we do this? So we work with communities and developers of evidence-based practices to really adapt interventions so that they are suitable to the communities that we are working alongside, to ensure they are ultimately culturally and linguistically appropriate. We provide resources and support so that agencies that are trusted by families, trusted within the community, can then go on to learn and deliver those evidence-based interventions and supports. And then lastly, we provide training and technical assistance on a variety of issues related to forced displacement across the arc of the crisis that families experience. So with that in mind, I will hand it over to my colleague Shafa, who's going to give a quick overview of the intervention that we're here today to discuss, PC Care. Shafa, I'll turn it over to you.
Thank you, Lena. So first of all, we're excited to have all of you interested in our new pilot. So PC Care, as my colleague mentioned, is for parent caregiver care. And it's an individualized treatment program that takes place in the child's home or in an office setting, but it's meant to take place where the coach, which gets trained by the team at PC Care, is working on working with the parents directly while interacting and watching the live interactions the parents with their children. So the interesting thing about it is that it's meant to build the skills of coaches, these parent coaches, so that they're able to support parents in understanding the behaviors that they see in their children, especially behaviors that parents might find quite difficult to manage, like tantrums or certain issues that they might see with children who have been through traumatic experiences or come from forcibly displaced backgrounds. And it's meant to be an in-person coaching experience. It's also meant to be culturally informed. So it's trauma informed in a sense that it keeps in mind all the different experiences that children may go through and helps to adapt to their experiences and manage the difficult things that they might have been through. It's also meant to be relationship based. So it's based on, it assesses and develops a relationship of the parent with their child, and also vice versa. How is the child interacting with the parent in return? It builds upon the children's strengths that are already there and helps to manage them in positive parenting strategies. Go ahead, Lena, if you don't mind moving to the next slide, please. So it's meant to be 7 to 8 sessions. There's a pre-session where a lot of psychoeducation happens and a lot of trust building happens with the parents. And then the rest of the sessions are meant to be based on the live interactions with the child and the different topics that the coach goes through with the parents. Things like how to manage the impact of stress and trauma and how that may impact the child's behavior, how to develop something called pride skills, or how to distinguish them, how to assess them, and addressing various temperaments, how to manage those in a healthy way, and generally assessing the child-caregiver relationship. So for the pilot, we're looking for participants that are parents and or caregivers, of course, keeping in mind that they may not be biological parents, that have at least one child between the age of 1 and 10. And they have to be US-based families who have experienced forced displacement. So either refugees who have been through, or who have been through any of forced displacement. We're also expecting for this pilot to take on 2 organizations, and we're trying to target certain languages so that our material is standardized, and we're looking for culturally and linguistically diverse families that speak either English, Spanish, and or Dari. The organizations that we're targeting are US-based public entities, nonprofit organizations, or government agencies that have a history of managing similar projects that will be able to recruit the participants that we're looking for and implement and train their coaches in the way that UC Davis intended to train the coaches for the program. And we're also looking for a lot of collaboration, coordination, and we do a lot of follow-up and consultation calls with the partners on that regard. Thank you, Lena. And I think I'm gonna pass it down to Jess.
Thanks, Shefa. Hi, everyone. So lovely to see so many familiar names and faces, and some that are unfamiliar. So just a little bit on what to expect and what we have in the expression of interest that we put out, that call for those expressions. Hopefully you all have reviewed it. We're reviewing just some of the basics. What we are hoping, if you want to partner with us on this opportunity, what you should expect from this opportunity is to have coaches. So identifying folks within your organization who would be appropriate to be trained as coaches, for these coaches and their supervisor to go through pretty extensive training. I know we have some former and current partners even on this call now. I think you all can probably attest to, and I think the fact that you're on this call is a good thing, but you can attest to how I would say involved that we are as a care team, and also UC Davis, our partner in this, will be. Our goal is to really be truly partners. So yes, while we're providing this funding for the opportunity, we are doing this so that we can learn alongside you all as you are hopefully benefiting from this wonderful evidence-based intervention and able to really support the families and children that you work with. So the training process for PC Care, it is detailed a little bit more in the call for expressions of interest, but it includes 2 training phases plus an implementation phase. So we will be alongside you every step of the way. So initial training, a training where you go through each session in a lot of detail, and then that training and prep for the very first cases that your teams will take on. Part of this is including, of course, recruiting families, both for your first training cases for the coaches, and then also additional families to continue to implement PC Care throughout the 9 months of this project period. We will include measurement and evaluation and other monitoring activities, because part of this is truly a pilot. So we really want to learn how this is working. Is this an evidence-based intervention that is adaptable, that we are able to use with diverse families who have experiences of forced displacement? And is it helping these families and children manage some of those difficulties that arise in that process of resettlement and integration, right? Because we know it's tough on the families that we serve. Part of our work, as I had mentioned, is that we are here as CARE and UC Davis, and we will have very regular calls with all of you. So you can expect a lot of support from us, which hopefully does feel supportive. I will say, not to brag on our team, but we are a team of practitioners who care about implementation and the actual work that you all are doing. So our goal is to best facilitate the partners that we are working with, the work that they're doing to best facilitate positive outcomes for the families and children that we serve. So our goal is to try to smooth things along, give you the resources to implement, and to have collective learning throughout this. Next slide, Lena. So funding details, there's a lot on this slide. I'm not going to read through all of it. And this is detailed also in the call for expressions of interest. But just to recap the important pieces, we are offering up to $50,000 for up to 2 organizations. So this is a smaller opportunity than those that we've had in the past in terms of the number of organizations and awards that we're able to give. This is funding that we have received from SAMHSA, the Substance Abuse and Mental Health Services Administration, and we are then dispersing this to our partners for this pilot. So we're looking for a 9-month commitment from January of 2024 through September of 2024. So looking at the next calendar year. This money is, we are hoping, if you are interested in submitting a proposal to us, that you can include your staff time, any travel expenses to go to homes, to be able to cover some project survey incentives, which we have some more guidance along that in the call for expressions of interest, and then program materials. Because this is money that we are receiving from our federal donor, we have to ensure that we and you all, potential partners, follow the SAMHSA guidelines. So we highlighted a number of pertinent and very relevant guidelines that are on this slide and that are also in the frequently asked questions section of the call for expressions of interest. So everything that is here is also reflected in that call, but we just wanted to pull out these are some of the most, as I said, salient, really important pieces. There are lots of different requirements and guidelines for our funding. And so if you are applying for this and we do move forward in working with you, we may come back and work with you to make some adjustments on the budget. Again, not because we don't think that we should cover participant transportation, childcare, or lost wages while they're part of this group, but because we cannot per our funder. You can go to the next slide, Lena. So again, we have a pretty, I'd like to think extensive, but hopefully not too long document to just give you the information that might be helpful for you to learn a little bit more about PC Care, to learn more about this project. And then we've also provided templates for both the budget and the narrative. We want this to be simple and short. We want to know enough to know about our potential partners, but not too much. So this is not, like a normal federal 60 to 70 page proposal. Please do not do that to yourselves or to us. So we really are looking for just some of the basics and the main pieces around your organizational experience, how you might be thinking about implementing PC Care, and then how you aim to fund this through the partnership funding that we have. Hopefully you have this, but if not, you can always access it on our website. And then we will make sure to share these slides out, which have lots of links. You can go to the next slide. Yeah. So last piece that I'll say, and then I think we will get to some additional resources and then questions, because that's the most important part of this time. But the submission, our deadline is Wednesday, September 20th. We know that's not a super long turnaround, and I know that August is vacation time for many of us. But again, we hope that this is a short proposal. We're looking for something no more than 5 pages, really trying to help y'all be concise and hopefully not have to put too much effort into this. And we hope to make decisions pretty quickly by the end of September or very early October, so that we can begin some of our fund partnership paperwork from October beyond to get us ready to go for implementation in January. Next slide. Here are just resources. Again, we're going to send this out so you have all of these hyperlinks. You can use them and make them work for you. But all of these are either linked on our website, which is careirc.org, or in the call for expressions of interest. I know that was fast, but again, this is the most important part. So we are here to answer as many questions as we can. So I'm going to stop talking and turn it over to all of you to ask us questions.
I have a question. Did somebody else speak?
We'll go Amy and then Jill. You got your next.
Okay, thanks. Yeah, I'm curious first, PC Care, I assume is like an adaptation of PCIT. I guess I'd like to know a little bit about the connection with PCIT and whether it's all, my understanding is that this pilot is about adapting it to the forcibly displaced population, and that hasn't already happened, and that PC Care was not created specifically for that population. And then my other question was just around the coaches, or like the 2 staff who would be doing the direct service. Do they need to be, have like a clinical license?
Great questions, Amy. So I'm going to try to go backwards, and I will probably forget some of the early ones. So help me with this, and Chef Alina looking to you as well. So starting with the coaches, they do not have to have a clinical license or clinical background. So coaches do not have to be licensed clinicians. We do recommend that the coaches have a mental health background or some kind of mental health training. PC Care is a wonderful intervention. It is also, I would say, intense in a good way, but intensive in terms of the information that's being shared in each session, and then also the live coaching. So the coaches themselves will be coaching the parents and caregivers with their children. And so that having that kind of background in facilitating groups or facilitating even psychosocial support sessions with clients would be helpful. The link to PCIT. Yeah. Before that, it was the specificity of this intervention with families who have experienced forced displacement. The intervention has not specifically been designed for families who've experienced forced displacement, similar to those of you who may be familiar, which I know Amy and Jill, you are at the very least, with attachment vitamins, which is our first kind of pilot project. These are interventions that were not originally designed with forcibly displaced populations in mind. And so we're working through that adaptation to say, hey, this is an evidence-based intervention that works with families and children, and oftentimes diverse families and children from different backgrounds, but not specifically with that eye towards forced displacement. So that is where we come in, and you all, hopefully, our partners will come in. And then the other question is the link between PCIT. So parent, child, oh my goodness, interpersonal psychotherapy? Interaction. Thank you, Amy. I'm like, the acronym alphabet soup in our brains is just a mess. So with that link to PCIT, this is the same team and the same developers of PCIT. These are considered to be separate interventions. And so PC Care and PCIT cover similar topics, but they are really looking at different situations in which families might be interested in engaging in the intervention. So PCIT is a bit more clinical, of course, in nature, and is delivered by a licensed clinician. PC Care is still reaching towards those same goals identified in PCIT, but at a bit of a step down from a clinical perspective, but not necessarily from the outcome perspective, if that makes sense. And our partners at PC Care can definitely explain this way more eloquently than I just did. So we can get a bit more of a thorough response from them on that too.
If I may add, Jess, also PC Care it is derived from PCIT, but it was meant to tackle the gap of why there's a dropout that was happening with PCIT. So it was meant to be shorter and kind of like more condensed for like parents and children. So this is from what I understood from the training.
Thank you.
Did I get them all, Amy? I didn't miss them? Chef and I got
I think you did. Yeah, thank you.
Hey.
Looks like, so Jill, I think Jill said she had her questions answered, but if you have any other questions, feel free to come off mute, Jill. And then we had Jessica. Jessica, feel free to, we'd love to hear from you on any questions you have.
Hey, I just had a question about having children from different programs participate because I work at Church World Service, Orange County, and we have a program for unaccompanied children. So we provide post-release services, but we also have a program for Afghan families and for Ukrainian families, and they also have children. So if we were to submit a proposal, would it be okay if we submitted a proposal for the entire office on behalf of all the programs?
Definitely. Yeah, this is not program specific. So this is no connection to any ORR funded program. So yeah, if you want to do it around, your PRS programs and you want to do it around any Afghan programs that you have, that is definitely welcome. Yeah.
Right, thank you.
course.
Oh, and I had one more question. If we're partnered with an outside organization that could possibly provide a coach that has more of a clinical background, would that be okay? If our staff doesn't necessarily have the background or the capability to do so?
Yes, we're open to that. We've worked with organizations who have partnered with other organizations in the past. Our goal with this is both to learn, of course, about this process and be able to get this intervention out. And it's to try to build capacity within organizations. So just from a self-serving for you, Jessica, perspective, we would love to see you have someone in your organization, because the goal is for you to have someone in your organization who's then fully trained in PC care by the end of this pilot, and can then continue implementing beyond. So that's just my plug for you and building internal capacity. But partnerships are welcome.
Thank you.
Hi, I have a question real quick if nobody's up next. First of all, thank you for Jessica. You took the words out of my mouth with the question about double dipping for the ORR. So thank you so much about that. Now, my question is just regarding the M&E for that. You said that y'all kind of have your own tracking methods of that. What does that look like? Because obviously we have a lot of ways that we track for our own internal programs, yeah, if you could expand a little bit on that, that'd be great.
I can take that one too. Chef and Lena, jump in. So our M&E, of course, we encourage that you all, whoever our partners are, that you all follow your own kind of tracking for provision of services. I'm sure you have a data management database that you're using. And so we want you all to continue doing that. We also will be asking for some data points around some standardized measures that are part of the intervention. So there's kind of pre-measures. There's also some data collection that happens throughout each of the sessions through both observation and then the parent and caregiver self-reporting. And then there's an end-line survey and some kind of post measures that we do. And so we request, we know this is a lot, so just going to say that out front here. But we request that all of the partners that we work with submit that data to us de-identified. So we don't want to know any identifying information, no names or dates of birth for your participants. We do ask for some demographics, but not identifying information. And we do that through a SurveyMonkey link for each partner. So we ask for that data to be submitted on a regular basis. We also, with our partners that we work with, we make sure that all the data that we've collected from partners, we share back in a clean version at the end of our project with partners, so that anything that you've shared with us, you also have for your ongoing learning and monitoring. Does that fully answer your question, Andrew?
Yeah, thank you.
I can
Yeah,
add something really
please.
quickly to that, Jess. And just to add to, so we on our end, as Jess mentioned, this is very collaborative. So we also have support throughout the partnership. If you have any questions that come up, troubleshooting, guidance, we really want to make sure that you have all the support needed. And then additionally, the one piece I want to make sure to ask, and Bijou, I know you have a question in the chat, is just that we also work on translating and culturally validating the measures that we use as well, so that you have those in language additionally. So just to add that bit. Right, and then I don't know if we've answered this, but maybe for Bijou really quickly, are there restrictions if a program is already funded by SAMHSA?
So there are not, I mean, I'm sure there are restrictions that exist, but in terms of having this opportunity, no, there are not restrictions. So if you already receive SAMHSA funding, even if you receive it through, this is part of our partnership with the National Child Traumatic Stress Network, you are also eligible and allowed to still apply for this and be a part of a partnership with us. So yeah, great. Thanks, Bijou. It was a good question. Shefa, yeah. Did
Bill
you
had
want
a
to take Joe's
question.
question? Yeah.
Yeah, so would this be a good follow-up for participants who complete attachment vitamins? Yes, and we think because there's so much overlap with concepts such as secure attachment and safe haven and how to deal with symptoms and signs of trauma that show up in behavior of children, and it's actually a really good follow-up for your staff as well, who already have that good background with understanding temperament, for example, so they can build up on that in a live interaction with parents and their caregivers. So definitely, I mean, I don't know, Jess, Lena, feel free to chime in, but from my perspective, I see it as the perfect segue. And it's kind of why we picked it, because we worked with children. So attachment vitamins was for 0 to 5, and this is for older children.
So feasibly a parent who completed attachment vitamins in the group setting, if they wanted to, get continued support one-on-one. With attachment vitamins, we're running it with, our Afghan community liaison together with kind of a mental health, psychosocial support specialist. Sounds like this would be directly in Dari, just with our Afghan community liaison. So we would remove that English-speaking psychosocial support specialist out of the equation, and just our Afghan colleague would implement herself directly.
Yeah.
Okay.
Because of especially in like the live coaching aspect, that's why we're looking at this to be directly implemented in language, because there's no way to effectively do live coaching with interpretation. There will always be that natural lag, of course. So there is that piece, which is why we also recommend having a supervisor or a colleague also go through that training, so that our staff who are implementing have a supervisor or colleague that has gone through the initial training and can provide that support and debriefing locally, in addition to our consultations that we will provide. But knowing that it's intense to do in a one-on-one situation. So wanting to make sure that we're building that internal capacity, both for the coaches, but also for their supervisory staff to support them, hopefully moving forward beyond the pilot.
Cool, thank you.
And I would just add, I think I completely agree with everything Shefa had said around this being a good follow-on to attachment vitamins. I would just add one piece, that it's a good follow-on to maybe some of the group-based support that you all are facilitating for families where they are identifying that their children, or the parents and caregivers may be struggling with some challenging behaviors, or learning how to manage some of the behaviors that their children are exhibiting. And those can be, I mean, there's a very wide range for what those behaviors look like. But it's really about kind of how do we use attachment-informed behavioral approaches to manage children as they get older, need to set some boundaries and support them through different stages and phases of development. Amy, I see your hands up.
Thank you. I'm assuming it doesn't have the same like bug in the ear, one-way mirror setup that PCIT requires. The coach is in the room with the, okay.
Yeah.
And then what was my other question? Oh, I saw in the RFP that it's the hope is for 2 coaches, each with 8 to 10 participants during the 9-month period. Is that kind of a 8 to 10 total, assuming, a couple fizzle out and don't make it to the end, or what are we aiming for in terms of like the total number?
Yeah, so I think the total number is that we hope, so we probably over recruit a little bit. So 8 to 10 completing. So yeah, probably recruitment somewhere between 12 to 15, I would imagine, per coach. Our goal in having 2 coaches from our partner organizations is that there's a cohort, that there's kind of that collaboration within the organization, so that that coach doesn't feel alone within their org and being the only one doing PC care. That's really what we hope. If you want to have more coaches, that's something that y'all can make work with the budget and the timeline and your staffing. We're open to that, but what we're really looking for are 2 coaches to be able to implement throughout those 9 months. Well, a little less considering the initial training, but
Thank you.
Could you speak a little bit more to what would qualify as mental health background? And I'm asking this because our program is set up that we work with clinicians, partially because it's very difficult to find community members with mental health background. And so we pair them up to deliver our programming. And so I can see a challenge having a cultural worker, for example, who has a mental health background to be able to do this. I'm just curious where the flexibility lies.
yeah, it's a fantastic question, Bijou. I would say that our kind of thinking around this is not necessarily like a particular degree or educational experience. It would be additional training. It would be a staff member who has some comfort level in speaking about mental health, about emotional wellness, in working with families, and more importantly, I would say in this case, working with children directly as well. So really just looking for that. I mean, if they have a background, a professional background and past experience, if your staff has that, fantastic. And if the staff members that you might want to have be a part of this also have the educational background, that's also fantastic, but that is not absolutely necessary. Just having at least that training and that support and a comfort level in this implementation. I don't know, Shefa or Lena, if you have anything you want to add on that. And then Jill, I see you're
Yeah.
off mute.
You absolutely nailed it. I think the thing that we're thinking about, of course, one of the big objectives of the care project is to be able to minimize those barriers between what a licensed professional is and what them being able to just like our demographics being able to access evidence-based interventions really easily. But one thing that came to mind as a concern is that since this coach is going to be working directly with parents in their own setting, preferably, they may, knowing that they've been through some difficult experiences that might be traumatic, there might be some triggers that might come up. Parenting is a very personal and sensitive topic. So we just want to make sure that the coaches that are chosen are able to handle any issues that might come up within that coaching session, if that makes sense. So it's up to you, I would say, to kind of figure out what that means, and we can help you through that.
Thank you.
What would you say would be like the estimated weekly time commitment? That would probably depend on how many, folks somebody's working with. But, let's say an hour a week for the coaching call, an hour or 2 for prep. And then is it just like, are those home visits, it sounds like, or maybe in the office, are those like an hour at a time, or what could folks expect?
Yeah, I think that's a great estimate, Jill, that you were kind of putting together, especially in the beginning. So especially for the first case where there will be those consultation calls, there's the prep, and then there's the actual going to the home or having the parent, caregiver, and child come into the office. It doesn't have to be within their home if that's not something that is conducive to the sessions. And the sessions themselves are less than an hour, though we imagine they might go over a little bit. And so they by no means will be longer than an hour. So the goal of PC Care is for them to be quite short.
And the sessions, some of them are done just with the parent and some are done with the parent and the child, or they're all with parent and child together?
all except for the pre-session. So the pre-session, and I'm looking at Chef and Lena to make sure I'm not misremembering anything, but the pre-session is with the parent and caregiver for the most part. The child is introduced a little bit, but a lot of it is that initial rapport building with the parent caregiver. But all of the other sessions are with the parent and caregiver and child fully, which is why they're meant to be shorter, around a half hour. But we also recognize that it might take a little bit longer. So there's some flexibility in there.
Yeah, thank you, everyone. Yeah, I'm being mindful of everyone's time, but thank you for everyone who stayed on. Yeah, any other sort of very final, maybe, I don't know if you can spend a few more minutes, any other last questions? Otherwise, as just mentioned, these will also be, yeah, on our website as well, the recordings, and we'll share out the deck and everything. Okay. Well, thank you everyone again. It was lovely, yeah, to see you all. Thanks for staying on longer. And we look forward to hearing from you as well. So thank you again.
Thanks, everyone. Take care.
All right. Okay. Okay. Thanks, Jess. Bye.